Imagine going to a cosmetic clinic, not for a facelift or, to smooth out a stubborn wrinkle or whatever, but to physically re-engineer your sex life.
Right. Yeah. It's a completely different mindset.
Yeah, because we usually think of aesthetic medicine as something you can instantly see in the mirror, right? But the industry is rapidly moving past the mirror and venturing, well, straight into the invisible.
It really is a massive paradigm shift. Aesthetic clinics are now heavily marketing procedures that focus entirely on how a patient physically feels.
Rather than how they look.
Exactly.
Right.
Which, opens up this incredibly complex frontier in medicine.
And today, Monday, May 18th, 2026, we are taking a deep dive into one of the most talked about, yet I would argue least understood examples of this invisible shift.
Oh, absolutely. There's so much confusion around it.
So we are looking at the intersection of cosmetic enhancement and female sexual wellness. Specifically, we're focusing on a procedure known as the G-Shot, or G-spot amplification, as it's sometimes called.
Right. And we have a really diverse stack of sources for you today.
Yeah, we pulled from everywhere. We've got clinical trial reviews, excerpts from the Journal of Sexual Medicine, statements from the American College of Obstetricians and Gynecologists.
Plus, we're looking at promotional materials and FAQs from various cosmetic and gynecological clinics around the world to really see how it's being sold.
Exactly. Because the mission here is to cut straight through the marketing hype and, well, the taboo, right? We want to understand what this procedure is actually doing to the body on a cellular and structural level.
And we also need to examine that stark divide between the clinic enthusiasm and the official medical skepticism.
Yeah, because there is a huge gap there. And most importantly, we want to answer the biggest question for anyone considering this. Is this a permanent fix or is it a recurring commitment?
Right, the subscription model aspect. But to even understand the procedure, we first have to, deconstruct the anatomy itself.
Because the G-spot is kind of a myth, right? Or at least the way we talk about it is.
Yeah, the term gets thrown around casually, but medically, the concept has very complicated history. It's named after Dr. Ernst Grafenberg, who was a German gynecologist.
Right, but wait, when you look at his original research, from the 1950s, he wasn't actually looking for a magic button, was he?
No, not at all. He was studying the female urethra, actually, and he just noted this erogenous zone along the anterior vaginal wall that seemed to swell during stimulation.
So he didn't even call it the G-spot.
Exactly. It wasn't until the early 1980s that other researchers coined the term to basically market the concept to the public.
Which totally created this lasting myth of a distinct, standalone organ just waiting to be pressed, like an elevator button.
Right, like an on switch.
Yeah.
But the clinical literature paints a much more intricate picture. The contemporary medical term for this region is the clitorethrovaginal complex.
Okay, clitorethrovaginal, or CUV complex.
A CUV complex, exactly. It is not a button. It is a highly interactive functional zone.
So what exactly makes up that zone?
We are talking about the area where the internal roots of the clitoris, the crura, and the periurethral tissue all converge.
And this is all sitting very close to the front vaginal wall, right?
Yes, typically located about 3 to 5 centimeters inside the vaginal opening. So when someone refers to the G-spot, they are actually talking about the stimulation of this entire interconnected network.
Okay, but for a long time, the scientific community openly debated whether this area even existed in a physically measurable way, right? Like, was it real or entirely subjective?
They absolutely did. But a landmark study from the University of L'Aquila in Italy, led by Dr. Emanuele Gianni, really changed the conversation.
Oh, right, the ultrasound study.
Yes, they brought ultrasound technology into the mix, which gave us hard structural data. Dr. Gianni's team used transvaginal ultrasonography to map the pelvic floors of 2 distinct groups of women.
And they're physically measuring the tissue, right?
Right. They measured the urethrovaginal space. That's the specific tissue between the urethra and the vagina. And the ultrasound images revealed something fascinating.
What did they find?
Women who reported experiencing vaginal orgasms had a visibly thicker, more robust region of tissue in that exact area.
Wow. So they could literally see the difference on a screen.
Yes. Conversely, women who did not experience them lacked that distinct tissue thickness.
Okay, so it provided tangible evidence that anatomical variations play a direct role in orgasmic capacity. That makes sense.
It does. It validates that this isn't just in someone's head.
But hold on, I'm trying to picture this physically. Because if the CUV complex isn't a specific localized button, but rather this whole scattered network of tissue, aren't doctors just blindly shooting filler into the dark? I mean, it sounds like trying to hit one specific hidden wire inside a highly complex circuit board.
Well, that's the thing. The goal isn't to hit a single wire.
Oh, it's not?
No, because this is a broad interactive zone. The procedure is designed to physically elevate the entire circuit board.
Elevate the whole thing. Okay.
Right. By injecting volume into that general submucosal space, you push the entire reactive area forward.
So you just make the whole network more prominent.
Exactly. Which practically guarantees that it will be stimulated during physical intimacy.
Okay, let's break down the mechanics of how they actually elevate that circuit board. The clinics advertise this as a lunchtime procedure.
Yeah, that's the marketing angle. Fast and easy.
Right, taking maybe 15 to 30 minutes. The patient is placed in the standard gynecological exam position. A local anesthetic is applied to the front vaginal wall, and then the doctor injects a dermal filler directly into the tissue.
Usually about 2.5 centimeters behind the midurethra.
And the primary filler being used here is cross-linked hyaluronic acid, right, or HA.
That's the one. And what's wild is this is the exact same biological material used in facial cosmetics to plump up lips and cheeks.
Right, so the same stuff they use in your face is going in there, and they are injecting a fairly significant amount, aren't they?
Yeah, anywhere from 2.5 to 5 milliliters, which creates immediate physical bulk.
Which, I should note, operates completely differently from the other prominent treatment in this space, right? The O-shot.
Oh, fundamentally different mechanisms. The O-shot does not use HA at all. It uses platelet-rich plasma.
PRP, that's the one where they draw your blood, right?
Exactly. They draw the patient's blood, spin it down in a centrifuge to isolate the platelets, and then inject that plasma back into the tissue.
But that doesn't create bulk, does it?
No. The mechanism there relies on releasing growth factors. The theory is that over weeks and months, these growth factors regenerate local nerve endings and blood vessels to increase intrinsic sensitivity.
Oh, okay, so it's a slower process.
Right. It does not create immediate physical volume like the G-Shot.
So, if I'm understanding this, the PRP is essentially repairing the underlying sensors of the tissue, whereas injecting hyaluronic acid for the G-Shot is, well, it's like installing a physical speed bump on a smooth road to guarantee the tires hit it.
That is a perfect analogy. That structural reality is the entire basis of the G-Shot.
Because HA is a humectant, right?
Exactly. Hyaluronic acid acts like a biological sponge. When it's injected, it doesn't just sit there as a static lump. It actively binds to water molecules.
Oh, so it actually pulls water in from the body.
Yes. It pulls in moisture from the surrounding tissues to create and maintain that structural volume. By expanding that tissue, sometimes outward by up to 2 centimeters, it physically projects further into the vaginal canal.
And that increased projection translates directly into friction.
Yes, and friction is what activates mechanoreceptors.
Remind us what mechanoreceptors are doing exactly.
They are the specialized nerve endings that sense stretch, pressure, and vibration. So when you have a larger physical surface area protruding into the canal, you naturally increase the mechanical friction against those receptors.
Which means more signals get sent.
Right. They fire off more electrical signals to the brain, which translates into greater tactile feedback during penetration. It is purely a structural solution to a sensory goal.
But, and this is a big but, because hyaluronic acid is a naturally occurring substance in the human body, which is, why it's well tolerated.
Yeah, the body recognizes it.
Right. But because it recognizes it, the body naturally produces an enzyme called hyaluronidase, and that enzyme gradually breaks the HA down.
It does. The HA metabolizes.
Well, yeah.
It dissolves.
And that brings us to the most critical reality for anyone considering this procedure: the duration and the absolute necessity of repeatability.
This is such a crucial point. The physical bulk created by the G-Shot is entirely temporary.
So how long does that speed bump actually last?
Well, across the clinical literature and the clinic data, the consensus is that the physical bump lasts anywhere from 4 to 6 months before flattening out.
4 to 6 months, that is not very long.
No, it's not. Some individual metabolic rates might allow it to stretch slightly longer, maybe up to a year if you're lucky, but the structural degradation is inevitable.
Meaning the treatment must be repeated to maintain the effect. Like, this isn't a one-and-done surgery.
Not at all.
To keep that enhanced physical sensitivity, touch-ups are mandatory, because once that filler is absorbed, the patient returns entirely to their baseline anatomical state, right?
Completely back to baseline. You are looking at a continuous, cyclical commitment.
I mean, think about what it actually means to schedule a medical injection into your pelvic floor in your calendar every 4 or 5 months, right next to your, dental cleanings and oil changes.
Just to maintain a baseline level of sexual satisfaction.
Yeah. We are basically talking about a subscription model for physical intimacy.
That's exactly what it is. And it operates on the exact same maintenance timeline as facial Botox or lip fillers.
Which makes sense since it's the same industry pushing it.
Right. The aesthetic industry is built entirely on this model of recurring revenue and routine maintenance.
But is it safe to just keep injecting filler down there forever?
From a medical safety standpoint, repeating the HA injections in this area is generally well tolerated over time. But it requires an ongoing financial and physical toll.
Yeah, it's not cheap, and it's still a medical procedure.
Exactly. Every injection is a new procedure, a new needle, a new healing process.
But wait, is there any compounding benefit? Like, if someone commits to this subscription model and gets injected 3 times a year for 5 years, does the body ever just, take over?
There actually is an interesting biological nuance there. When you repeatedly introduce a needle and a foreign substance like HA into the dermal layers, it causes mild localized trauma.
Which sounds bad, but it isn't.
Well, that trauma, along with the physical stretching of the tissue, can actually stimulate the body's own fibroblasts to produce collagen.
Oh, wow. So you're tricking the body into building itself up.
Essentially, yes. Over an extended period of repeated touch-ups, that localized collagen production might create a slight permanent thickening of the tissue.
Okay, so maybe the speed bump becomes a little more permanent over time.
Well, the HA always dissolves,
Hmm.
but the intervals between those subscription visits might gradually lengthen as the body builds its own subtle structural support.
Even with that potential collagen boost, a subscription model for intimacy just carries a really heavy psychological weight.
Oh, a massive psychological
Hmm.
weight.
And while cosmetic clinics love to frame these routine touch-ups as quick, easy lunchtime maintenance,
Which is such a weird way to phrase it.
seriously, taking a needle to a highly vascular, incredibly sensitive area multiple times a year is not something the broader medical community takes lightly at all.
The contrast between the aesthetic clinics and the major medical institutions is honestly jarring.
Let's talk about that. What do the big medical bodies say?
Well, the American College of Obstetricians and Gynecologists, or ACOG, has issued firm guidelines stating there is no valid medical indication for this procedure.
None. They just flat out say there's no medical reason for it.
Correct. They emphasize that it has not been proven safe or effective in robust, long-term, randomized clinical trials.
And the regulatory side is just as strict. The FDA has never approved hyaluronic acid fillers specifically for vaginal use.
Never. Every single G-Shot performed is an off-label procedure.
Off.
Yes. The physician is taking a product explicitly approved for facial tissue and using it in the pelvic floor, based entirely on their own clinical discretion and the patient's consent.
Which feels risky, right? Because altering the spatial dynamics of the pelvic floor introduces distinct anatomical risks.
The anterior vaginal wall is a highly delicate neighborhood.
What kind of risks are we talking about here specifically?
Beyond these standard injection risks of localized bleeding or infection, you run the risk of filler migration.
Oh, meaning the HA actually moves.
Yes, the HA physically shifts away from the CUV complex and creates uncomfortable lumps elsewhere in the vaginal wall.
That sounds awful.
It is. There's also the risk of dyspareunia, which is the medical term for pain during intercourse.
Which is the exact opposite of what you're paying for.
And that's often caused by nerve irritation or improper filler placement.
But there's another anatomical risk in the sources that really highlights just how delicate this space is, and that involves temporary urinary retention.
Yes, that's a very specific risk to this procedure.
Because the CUV complex sits immediately adjacent to the urethra. So, if a doctor aggressively overfills the area, or if the HA pulls in too much water and swells significantly,
Like that biological sponge we mentioned.
right, that volume can literally compress the urethra. It pinches the tube, making it difficult or painful to pass urine until the swelling subsides.
You have to remember you are introducing 5 milliliters of fluid directly next to a narrow vital channel.
That's a lot of fluid for a small space.
It is. The margin for error is incredibly small, which is why ACOG pushes back so hard against treating this as a casual cosmetic touch-up.
But this brings up a huge contradiction, because if the major medical organizations are raising all these red flags,
Right.
and the FDA considers it off-label,
Right.
how do we explain the clinic data? Because recent pilot studies from these aesthetic centers report satisfaction rates as high as 87% among women who commit to the procedure.
87% is a massive number.
Right. We have to reconcile clinical skepticism with the overwhelming anecdotal success being reported by the patients themselves. They love it.
But reconcile that We have to look at how success is measured, and more importantly, the psychology of sexual medicine.
Which is a whole other beast.
Exactly. Clinical trials demand double-blind, placebo-controlled data to prove that a physical intervention works independently of the mind. ACOG requires that gold standard.
But in the commercial space.
In the commercial space, subjective satisfaction is all that matters to the patient. If they feel better, it worked.
And the brain is arguably the largest and most powerful sex organ.
The placebo effect in sexual medicine is profoundly strong. Think about it. When a patient actively researches a procedure, books an appointment, pays potentially over $1,000 out of pocket,
Right, it's investment.
a huge investment, and then they undergo a physical intervention specifically designed to enhance their pleasure. The psychological expectation alone is massive.
So just expecting it to work actually makes it work.
Yes. That expectation can actively decrease performance anxiety and significantly enhance arousal.
And honestly, the act of getting the G-Shot might also serve as a catalyst for communication, right?
That's a great point.
Because a woman who seeks this out is likely having more open, direct conversations with her partner about her physical needs and desires, which, can dramatically improve sexual satisfaction regardless of how much friction a hyaluronic acid speed bump is creating.
Oh, absolutely. The 87% satisfaction rate is likely a potent combination of both factors.
The physical and the mental.
Right. You have the actual mechanical friction provided by the HA filler activating those mechanoreceptors, but it's supercharged by a massive psychological and emotional boost.
But this brings up a really critical distinction regarding what this subscription model actually treats, because it addresses mechanics.
Strictly mechanics.
It is designed for someone who already has normal sexual function but just wants to structurally amplify the physical sensation.
That is the key right there. It absolutely does not treat systemic, hormonal, or psychological drops in libido.
Like HSDD.
Right. Conditions like hypoactive sexual desire disorder, or HSDD, involve a chronic lack of sexual interest or desire, often rooted in neurotransmitter imbalances or emotional distress.
So you can't just inject filler to fix that.
You cannot inject physical volume into the vaginal wall to cure a lack of intrinsic desire. Treating HSDD requires psychosexual counseling, hormone therapy, or specific medications.
The G-Shot is a structural tool, not a chemical or emotional remedy.
Precisely. It's a localized physical enhancement, nothing more.
Okay, so let's pull all these threads together for you, the listener. We started by dismantling the myth of the G-spot as a simple magic button, looking at the history from Dr. Grafenberg to Dr. Jenny's ultrasound studies.
Which really helped us understand the clitoridiovaginal complex as a rich interactive network rather than a single point.
Then we examined the mechanics of how hyaluronic acid acts as a humectant.
Right, pulling in water to create a physical speed bump that increases friction and triggers those mechanoreceptors.
And then we confronted the reality of the subscription model, the fact that because this filler naturally dissolves, maintaining this physical enhancement requires a continuous cycle of touch-ups every 4 to 6 months.
Which is a heavy commitment. And finally, we balanced those high subjective satisfaction rates, which are driven by both mechanics and the powerful placebo effect,
Against the strict warnings from medical bodies like ACOG regarding off-label use and anatomical risks like urinary retention.
It really perfectly captures the tension of modern aesthetic medicine moving faster than traditional clinical consensus.
It totally does. Which leaves us with a final thought for you to mull over as we wrap up today's deep dive.
It's a big philosophical shift we're seeing.
Yeah. Because as we develop more advanced tools to physically treat intimate wellness, we are increasingly viewing sexual pleasure as a mechanical, structural issue, something to be plumped, filled, and scheduled for routine maintenance.
Right next to your Botox.
Exactly. But if we normalize the idea of injecting invisible speed bumps in the pursuit of enhanced friction, at what point do we risk medicalizing perfectly normal anatomical variations?
It's a slippery slope.
It is. Could the immense pressure to mechanically engineer the perfect physical response end up distracting us from the deeper, complex, emotional, and psychological roots of human intimacy?
Well, as the science evolves, our definition of what is normal seems to be shifting right along with it.